I'd like to introduce our next speaker. It's Dr. Janice Blair, who's a professor of medicine at the Mayo Clinic, Scottsdale. Janice has done a phenomenal job in working on coccidioidomycosis, particularly in transplant patients and patients with other immunosuppressed diseases. And we're very thankful that she joins us. And so she's going to talk about managing disseminated disease.
And thanks again to the organizers for allowing me to participate in this. It's an honor and a privilege. Today we'll go over treatment of coccidioidomycosis. And I will try to fly through some of the stuff that Dr. Impel has already touched on. And some of it I think is probably worth stating twice. So I am aware that we will do some overlap here. I have no conflict of interest to disclose, but I do need to let you know that almost everything we're going to be talking about today will be FDA off-label. And the only FDA-approved medications with an indication for cocci are ketoconazole, if you're so inclined to use that. And there are times when that may be something you want to do. And the old-fashioned amphotericin B deoxycholate, the hard on the kidneys, put them in dialysis in 3 days sort of thing. Those are the only ones. Everything else is going to have an off-label indication. So we start off treating cocci with a very careful history and physical exam. One of the things you need to do is define the severity. That won't be hard to define, but also the location and the chronicity of the infection, because by answering each one of those aspects, you're going to have a better sense of the type of treatment you're going to need. And you especially want to know if there are if there's any evidence of extrapulmonary cocci. So we need to know if it's in the skin and the soft tissues, bone and joints, or the central nervous system. So I'm going to camp a little bit on the therapeutic agents that we have in our armamentarium here. And I just want to make a plug. It is perfectly acceptable and actually probably recommended that for mild cases of cocci, primary pulmonary cocci, especially, and I use Dr. Empel's rule too, if it's already getting better, by the time they see me, I don't use antifungal treatment. And in fact, if you think about it, so many of them we don't end up treating, because they're getting the Levaquin for what turns out to be primary pulmonary cocci. And then you just don't have to add any antifungal after that. And Dr. Impel has already gone over his data showing that it doesn't decrease the rate of dissemination or complications. So what about amphotericin B? It was the first medication that showed any efficacy against the coccidioidomycosis. It can be given IV, intrathecally. You can inject it into a lesion, into the joint. But the only thing you can't do is take it orally and have it be absorbed. The IV was known early on not to be effective for cocci-meningitis, and back when we were using it for cocci-meningitis, it had to be given intrathecally. It has this perception. There has never been a trial of amphotericin B in cocci infections. It was just the first thing that worked, so it got used. And some people have this idea, and I have to say, you always feel better if you have a patient who's rapidly running away and declining with cocci. Feel like you're doing something more if you give that amphotericin B, but we don't have any studies showing that is a true to life situation. And so if you're going to use the old deoxycholate preparation, the dose would be 0.5 to 1.5 milligram per kilogram. You can give it daily, or if they're struggling with renal insufficiency, every other day is fine too. It is fraught with toxicity. It's hard to take when it's going in. Patients will frequently, as it's being infused, have fever and rigors, hypotension, lots of symptoms. And then, of course, the cumulative toxicity is that the creatinine starts going up and the patients will waste potassium and magnesium. the lipid-associated amphotericin Bs have pretty much taken on the market when we do use an amphotericin. And they were developed as a safer alternative to the first round of amphotericin. There are 3 formulations that are available in the U.S., and amphotericin B cholestyryl sulfate complex, amphotericin B lipid complex, and liposomal amphotericin. It all depends on what the configuration of the lipid molecule is. There still are acute febrile reactions, though they are less frequent, and some formulations seem to have less of the febrile infusional reactions than the others. All of them have lower kidney toxicity. They're all expensive. And again, there's no data that compared the lipid formulation with the old-fashioned amphotericin B or that one is better than the other over azoles.